The team was concerned about abdominal issues, and the next few days she was reviewed by the surgical team and was taken for laparoscopy. The laparoscopy didn't find any issue with the abdomen. She was then noted to have a murmur. There was a family history of thick heart in maternal grandmother that was thought to be caused by systemic hypertension. And then there was also a family history of early maternal death in the maternal auntie, which remained unexplained. Parents were healthy, not consanguineous, and there was another half sister who was at the time, I think 7, who was well. This is because of the match.
We're not seeing the slides moving. Are they meant to be moving?
Yeah, they should move.
Okay. That's it. Yeah, they're moving now. Yeah.
Okay. So let's see if I do this. So because of the murmur, the baby had an echocardiogram. For people who are not familiar with echocardiogram, this is a personal long axis view. You can see the left atrium, left ventricle, right ventricle, and the aorta. You can see the heart is quite thick, both right ventricle and left ventricle, and the myocardium looks a little bit speckly. This is a 4-chamber view. On your right side, you have the left heart, left atrium, left atrium, left ventricle, and on right, left side of the screen, right heart, right ventricle, right atrium. You can see again this thick heart, and you can see some flow acceleration there, and the baby had severe left ventricle outflow tract obstruction. And you can see also some black space here around the heart, which is a pericardial effusion. Second case, neonate, born at term, uneventful pregnancy, presented with fever and grunting at 1 hour of age. Mum was treated with antibiotics at the time of delivery because of fever 12 hours prior to delivery. It was an Afro-Caribbean family, non-consanguineous parents. The baby was admitted to neonates and started on antibiotics after a septic screen, which was all negative. On day 7, there was increase in respiratory distress, and the baby was noted to be persistent tachycardic and was started on CPAP. Chest X-ray showed cardiomegaly. And this is his echocardiogram. Again, 4-chamber view, left side heart. You can see the left ventricle is poorly contracting, is dilated. The atrium is dilated. This is a view focusing on the left ventricle. You can see some brightening here, meaning scar of the ventricle. And with color, you can see severe matter regurgitation in the poorly contracting left ventricle and dilated left atrium. So what is cardiomyopathy? Cardiomyopathy as a term was first introduced more than 15 years ago and has undergone multiple revision of the definition as knowledge. We gain more knowledge. Last definition is quite old, 2006 from the American College, and the from 2008, the European Society of Cardiology. According to the American College of Cardiology, cardiomyopathy are a group of disease of the heart that are associated with mechanical and or electrical dysfunction that are that exhibit with inappropriate hypertrophy or dilatation, and usually are genetics. They are the cardiomyopathy can be confined to the heart or can be part of generalized systemic disorders. this is the classification according to the American Heart Association, just to make things more easier. Cardiomyopathy can be divided into primary and secondary. Primary are genetics, and they can include cardiomyopathy, so hypertrophic cardiomyopathy, and the main phenotype, hypertrophic cardiomyopathy and dilated cardiomyopathy. And the American Society of Cardiology includes the channelopathies, which I won't mention in this presentation. And the secondary one are the one for which we can find a cause, like tachycardia induced dilated cardiomyopathy, or infant of a diabetic mother with hypertrophic cardiomyopathy. The burden of cardiomyopathy in children is quite rare, is about 1.2 per 100,000 cases, and DCM is accounted for more than half of those. We know from previous studies that roughly 40% of children undergo heart transplant or die within 5 years of being diagnosed. Neonatal cardiomyopathy represent 1% of pediatric disease, and often is the most severe presentation. And neonatal cardiomyopathy are responsible for 10% of all pediatric cardiac death. When we assess a cardiomyopathy in a neonate, which should be systematic, and it's not just the neonatologist and the cardiologist involved, but also we need to seek advice from experts in metabolic medicine and geneticists. Finding the cause for the cardiomyopathy is crucial because some can be treated, and we can plan the medical management, and we can be more sure about the prognosis, and we can predict some complication. Unfortunately, medical therapy for the one we can, the primary one, has a limited role just to support with symptoms, and it does not change the prognosis. When we assess a patient with cardiomyopathy, we should get family history. If there's any family history of cardiomyopathy or sudden death. Prenatal history is really important. We should ask for use of steroids or diabetes in mom. From a cardiology point of view, ECG and echocardiogram are really important. ECG can show us clue and direct us to more common diseases. I will show you later. And echo can help us to differentiate between the two common phenotypes, dilated and hypertrophic. Blood tests are really important to find out the cause of the cardiomyopathy. Metabolic tests are performed, urine tests like organic acids and amino acids. Lactate is really important. And from cardiac, troponin and BNP. Troponin can be elevated but really high in patients with myocarditis, for example. BNP is a biomarker that tells us how sick is the heart and is produced by the heart in response of stretch. And it can be useful to know how well the patient is responding to the medical therapy. If myocarditis is suspected, viral PCR is really important. Adenovirus, enterovirus, parvovirus are the most common one. Skin and skeletal muscle biopsy are usually not used as first step, but if we think of the cause of cardiomyopathy to be mitochondrial metabolic, can be really useful. Endomyocardial biopsy is rarely used, especially in neonates, because of high complication or related to the procedure. ECG is really important. Coming back to ECG, and it can give us red flags. For example, a short PI interval can be seen in, for example, Pompe's or mitochondrial disease. AV block is common in mitochondrial disease, for example. Extreme left ventricular hypertrophy can be seen in Pompe's. If we think about syndromic cardiomyopathy, extreme superior axis deviation can be found. How the cardiomyopathy neonates present in more than 50% of cases with a systolic murmur. This can be due to left ventricular hypertrophic tract in hypertrophic cardiomyopathy or severe mitral regurgitation dilated cardiomyopathy. Heart failure symptoms in less than 30% is frequent in the DCM subgroup. Arrhythmias can be present in 25% of the patients diagnosed with DCM. Obviously, in all patients with tachycardiomyopathy. Dysmorphic feature, hypotonia, hypoglycemia are clue. Cyanosis is not a presentation of neonatal cardiomyopathy, and usually is related to right-left shunt. Causes of neonatal cardiomyopathy, most of all syndromic, for example, Noonan in hypertrophic cardiomyopathy, and metabolic causes are like Pompe's or mitochondrial. Familial cases are very rarely diagnosed in neonates. Don't forget the secondary cardiomyopathy like arrhythmias, low calcium, hyperinsulinism, and myocarditis. Just a quick slide on inborn error of metabolism, and Dr. Ghosh will explain you everything about it. Inborn error of metabolism are a disorder of the metabolic pathway resulting in failure or breakdown of or storage of carbohydrate, fatty acid, and or glycogen or proteins, and usually they present with hypoglycemia or accumulation of toxins, for example, ammonia. These are inherited as autosomal recessive pattern, but rarely can be autosomal dominant and X-linked. And they are responsible for 26% of the cases of hypertrophic cardiomyopathy and 16% of cases of DCM. And they can be divided in 5 main groups. I'm not going into that, but they are the most common cause of cardiomyopathy in neonates. Be more in the specific into subgroups, hypertrophic and dilated cardiomyopathy. Hypertrophic cardiomyopathy is defined where the voltage is increased, and according to the most recent guidelines of hypertrophic cardiomyopathy published in November last year, the Z-score should be more than 2.52 in the presence of family history. The hypertrophy is not caused by any other condition, for example, aortic stenosis. The heart becomes thick and it can cause obstruction in the outflow tract. Pressure in the left ventricle can increase back in the left atrium and backwards in the pulmonary system, and can present with pulmonary edema. The hypertrophy can involve any segment of the heart and can be global or asymmetric, involving just the septum, and can be biventricular, and this can give us a clue of this to be more caused by, for example, mitochondrial or metabolic. Nearly 25% of hypertrophic cardiomyopathy present in first year of life, and usually have a poor prognosis, usually related to heart failure. Causes, most common causes, as explained before, syndromic. Neonate is the most common, and inborn error of metabolism, pompes, for example, and a mitochondrial defect. Don't forget infant of a diabetic mother or congenital insulinism. Sorry, and usually is reversible. Sarcomatic familial cases are rarely diagnosed in neonatal period. This should move, but if I show it in the presentation, it doesn't show. This is results of recently published European missing center study, and it leads participating in this study. They looked at the incidence of hypertrophic cardiomyopathy in pediatric age. And if you can see in infants, the most common cause are inborn error of metabolism and restopathies. And as you go along with years, inborn error of metabolism and syndromic are becoming less and less. Survival is quite poor for inborn error of metabolism. They usually died before 1 year of age, and restopathies. And if you look at the causes of death for inborn error of metabolism, most of all is non-cardiac, but you can have sudden cardiac death as well. And this is important for counseling as well. And restopathies can have sudden cardiac death or non-cardiac. Presentation usually is murmur, as explained before, due to left ventricular outflow tract obstruction. They can have dysmorphic features. DCG is often abnormal, can have left ventricular hypertrophy, ST changes, or short PI interval. Don't forget to ask for a family history of hypertrophic cardiomyopathy or sudden death. This is the ECG of the case I presented before. So you can see there's quite high voltages, and the PI interval is quite short, and is like delta wave, like pseudo pre-excitation. Is not a real pre-excitation, and this points out towards more mitochondrial metabolic disease. And actually, that case I presented before was in fact a mitochondrial hypertrophic cardiomyopathy. Management, medical therapy is used for relief of symptoms and is not changing the prognosis. Beta blocker are used as first line in neonates. Surgical therapy like myomectomy, usually we don't use it in neonate because of high risk of transplant. Might be necessary, but you need to bear in mind the limitation of organs and the small weight. So it's often impossible to get a transplant in a neonatal period. Enzyme replace therapy and supporting therapy can use for an inborn error of metabolism when if enzyme replacement therapy is available. It's not available for all conditions. Dilated cardiomyopathy is defined by dilatation of one left ventricle or both ventricle with poor function, and is most common cause of cardiomyopathy. Affect all age groups and is most common below the 1 year of age, and in 20% of cases it presents in neonates. Presentation, usually neonates present with signs of heart failure, They can have tachycardia with decreased perfusion. They can have a murmur caused by mitral regurgitation. They can have gallop. They can have hepatomegaly. Abnormal ECG as well, with ST changes and conduction delay and arrhythmias. Myocarditis can present with arrhythmias, both atrial and ventricular arrhythmias. This is the ECG of the patient I presented at the beginning with dilated cardiomyopathy. You can see it's quite fast, almost 300. You can see ST changes, ST elevation here, ST depression there, and in lateral leads here. Quite small voltages, Q waves in the lead 1, lead 2, and AVL. You can't see the P wave, so it's an SVT here. And actually, the patient was diagnosed with enteroviral myocarditis.
Grazia, we're running a bit short of time. Do you think, would it be